My name is Thomas Reiner, and so my presentation will follow a little bit of a different tack. I'm an imaging scientist here at MSKCC, and what we are doing is what our mission is really to improve detection and monitoring of disease. So it's we are developing imaging tools, optical imaging tools, radioactive imaging tools, to enable our physicians to have a more precise understanding of our patients' tumors. And so there's one disclosure I have to make. I'm a co-founder and shareholder of Summit Biomedical Imaging, which is a tiny startup out of MSKCC. And so when you look at the existing standard of care with what we typically do, FDG scans, then you will find that FDG is actually pretty good at predicting preoperative chemotherapy or chemoradiotherapy. And so having 18F FDG, we can pretty much tell very nicely if somebody is going to respond to chemotherapy. But what FDG cannot do is FDG cannot predict all those new and more complicated targeted markers or immunotherapeutics. And that is basically shown here, right? So as soon as somebody has a regional or more distant cancer, it is very hard for us to understand what are our patients going to respond to, and it is also very hard for us to switch over from one therapy to the next quickly. And simultaneously, most patients with gastric cancer are being diagnosed when their cancer is not local, when it's regional or distant. So in detail, I would like to focus on three different new developments we've made here at MSKCC. One of it is an imaging agent for HER2. The second one is an imaging agent for PD-1, an immunotherapeutic and checkpoint inhibitor, and the third one is a non-invasive screening tool for PARP1. So jumping, in the interest of time, jumping right into this, as most of you might probably know, 20% of gastric cancers do express HER2, and trastuzumab is an antibody which is approved for metastatic HER2-positive breast cancer. What we do not know when we inject patients with trastuzumab is how much of the trastuzumab actually makes it to a given lesion. Right? We don't know how much of the drug actually makes it to the primary tumor, how much makes it to the metastatic lymph nodes, how much makes it to the metastatic sites. These are all unknowns. The only thing that we know is that at least one of the lesions expresses HER2. So our goal here was to come up with a plan, to come up with an imaging agent which would tell us if we actually hit our target and how fast we hit it. And we also would like to have a look at the heterogeneity of receptor expression and help our physicians to have an online monitoring tool to have a look in how well our drug hit its target and to have an immediate response to our treatment. And so we started off with mice, and so you have a mouse here, up here, with two different tumors, and one of them is HER2 positive, and one of them is HER2 negative. And this is also a situation which could be possible in a human, right? That we have one lesion that does express HER2, and the other one doesn't. And so if you give this mouse trastuzumab, then one of the lesions takes up the trastuzumab, and the other one doesn't. So the logical consequence here is if your patient has multiple lesions, one of them expresses HER2, one of them doesn't express HER2, then you will be able to treat one of those lesions with trastuzumab, but the other one just keeps growing because it doesn't receive any of the drug. And intuitively, we wouldn't be able to biopsy every single lesion of a patient, right? We would only be able to biopsy one lesion or two, or maybe maximum three. And who knows if we miss that very, very one crucial lesion that doesn't express HER2. And so this work was done by Narissa Viola-Villegas, who used to be one of Jason Lewis's postdocs here at MSKCC. And Narissa is now an independent assistant professor at Wayne State, I believe. So the very same thing we translated to humans, and this is a absolutely mind-blowing example of how powerful these 89 zirconium, these PET imaging agents based on drugs, can be. You have this very prominent lesion up here in this patient with gastric cancer, and so that patient was treated with afatinib for 1 week, which is an irreversible HER2 inhibitor, and you can very nicely see two things. So first of all, that lesion up here is practically gone, right? So you can't see it at all anymore. Here's a top view. So this lesion is practically gone, but also these two other lesions, very, very highly HER2 expressing. One of them had a major response, but the other one didn't. So this is all information that would be completely obscure to a physician who didn't have this tool available. So in this case, we were able to better understand the disease, to better understand the response of our patient, and we hope that companion imaging diagnostics like these will become the standard of care in just a couple years down the road. So far, we've imaged 25 patients, and these are Joe O'Donoghue and Jorge Carrasquillo, who together with Dr. Janjigian pioneered this study. And 25 patients, and we published the pharmacokinetics, and we found, and this is really striking and confirmed our hypothesis, that there's really a surprising heterogeneity in baseline uptake of those patients that express HER2. So the biology is a lot more complicated than we can see with just a simple biopsy. Another case where the biology is extremely complicated is our immune checkpoint inhibitors. And so we know that immune checkpoint inhibitors, they work for some patients, they work extremely well, right? For some patients, immune checkpoint inhibitors really result in miracle cures, but other patients don't benefit. So Keytruda, for example, helps in 60% of all patients, 30% don't respond, and we don't really know why that is. So here what we are doing is we are developing this next set of imaging agents for PD-1, PD-L1, and in order to get a better understanding of which lesions express our markers, at what times do they express it, and do all lesions express it. And our big hope is that this will give us a better understanding of how to treat a patient, with what to treat a patient, and also at what time to treat a patient, and also when to switch therapy to the next treatment regimen. When you think back to that first introductory slide I gave you, there is esophageal cancer and gastric cancer. Most patients actually get diagnosed when their disease is regional and distant, and this is also what we heard in our talks before. And so what my lab has been focused on for the last 2 or 3 years is a target that's called PARP1. So PARP1 is a DNA repair enzyme, and we found that in oral cancer, PARP1 expression increases over the course of the disease. So if you translated this to esophageal cancer, you would find that a healthy esophagus has only very low PARP1 expression. But as you go from Barrett's esophagus to low-grade dysplasia, medium to grade, and high-grade dysplasia, your PARP expression will go up until eventually it becomes sky high when it comes to metastatic cancer. This is a more general trend and has to do with the harsh environment that a tumor cell lives in and the need for increased amounts of DNA repair. And so at MSK, what we did is we used this feature to create a kind of Listerine type of cup. And you can envision this as part of your dental visit. After you get your teeth checked or your professional cleaning or something, you typically have this small plastic cup that to swish and spit. So our version of this plastic cup has an imaging agent. Has an imaging agent which adheres to potentially dysplastic or malignant lesions. And so we've tried this out so far. We are currently doing a phase 1 dose escalation study. Yesterday we had our 6th patient. And so we found that this imaging agent is actually really powerful at highlighting oral cancer. And it's actually so powerful that we thought, if this works really well in oral cancer, why don't we try this out in esophageal cancer? And we were in this very fortunate position to get biopsy specimen which show healthy mucosal and submucosal tissue, plus in some cases squamous and then adenocarcinoma. And so we found that for esophageal cancer, the PARP expression for full-blown esophageal cancer is actually a lot higher, even higher than for oral cancer. The only than for oral cancer. And so what we did then is we tested our imaging agent similar to what we did with HER2. We tested our imaging agent and looked if we can highlight this cancer. And this is in this case a different kind of mouse. The mouse has a tumor sitting on its back. We took the skin off so that we can actually look at the cells of the tumor. And when we inject the imaging agent, at first, what you saw here is a blood vessel, and what's green is the actual imaging agent. So the imaging agent makes it out into the tissue, basically floods every cell, and gets retained in the cells that harbor PARP1. So this is a very specific imaging agent. It'll go into every single one of your, if you were injected with this agent, it would go into every single one of your cells, but only sticks like Velcro to everything that's PARP1 expressing. And we know that esophageal cancer and oral cancer do express a lot of PARP1, so that's what we use to basically highlight the cancer. This is also very, very specific. This is here to the left in green, again, is our imaging agent. This is an immunohistochemical slide, so this highlights the actual enzyme, and this is a standard of care H&E histology. One thing that I would like to highlight here is that this image here to the left took us about 15 minutes. The image here in the middle takes about 3 days, and H&E, if it's paraffin embedded, also takes 2 to 3 days. So this imaging agent, the small molecule that we developed, is really an in vivo contemporaneous imaging technology that we could do in the operating room, that we could do in an outpatient setting, or that we could do, as I mentioned before, in a dentist setting, right? And the one issue we have with the esophagus is that it's not easy to reach. And similar to these approaches that we looked at before, what we did, and we did this in a Yucatan pig, which is about 25-ish kilos, so this size roughly. We had these plastic balloon catheters that we decorated with sponges, and we soaked the sponges in our imaging agent, and the pig was under, so we put the catheters into the esophagus, inflated the esophagus, and then the sponge would release the imaging agent. And that took about 1 to 2 minutes. Well, no, 3 minutes. 3 minutes of topical application in vivo. And here you see the mucosal surface of a pig's esophagus. And lucky for us, a pig has a lot more mucus glands than a human. And these mucus glands we can use as an indicator for how far our imaging agent goes in, because they express a lot of PARP1. And so we find that our imaging agent travels through the tissue when applied topically at a rate of about 4.6 micrometers per second, which sounds very little. but that means that, that we really just need 2 minutes of exposure to get the mucosa completely stained and see what we want to see. And a potential readout, also suitable for the esophagus, could be this instrument. Could be this instrument here. This is a Fiberoptic scope, and this is actually an image that we, here in the background, you can see a tumor which is being imaged right now, a tiny piece of tumor, and this instrument gives us a video rate analysis of what a tumor would look like. And like listening to these earlier talks, we could as well use this in the stomach. We could look at occult lesions, and then for occult lesions, we would be seeing something disordered like this, which would clearly indicate that this is a cancer, as opposed to the normal physiological structure, which would give you an online, contemporaneous, non-invasive H&E, so to speak. And at this point, and I hope I wasn't talking too long and caught a little bit up in time. Summarizing up, so our mission here really is to make imaging detection and our understanding of what's going on biologically better. And we believe that we are on a very good route when it comes to PD-1 and HER2. And we believe that we can make it better, that we can make treatment and diagnosis more precise. And as for part 1, we really hope that we can improve the detection of both oral cancer as well as esophageal cancer, make these diseases detected earlier, because that obviously is one easy way to increase the 5-year survival rate. And thank you very much for your attention.